Hi guys, and welcome to today's video where I'm going to talk you through my on-call queries. So I've done this twice before and this is the third time that I'm doing it. I don't always do it, it depends on the amount of queries that I get and stuff. But this time around I was like, this was just like a hefty on-call. Like I really did struggle this time, and that's because usually my on-calls have always been on a weekend, but this time I got the weekdays and I found it so hard to actually like go to work, do the full day, and then continue working all until the next day. People from residency are going to be like, oh my gosh, please stop complaining, and I get it. But like with residency, at least you're actually on site to be on call, so you're already there. Whereas my trust, the on call is like taking the laptop home and hoping that you don't have to get called in, which I did get called in this time, so I did struggle. But yeah, I just thought, you know what, let me film and let me tell you what these queries are again and just share them with you guys as you find it helpful. Just like in all of my normal on-call videos, I am not going to talk you through every single query that I got, because if I feel like it's not really varied or if it's repetitive or it's a bit stupid, then I'm obviously not going to talk about it. It's just going to be like a few of them that I got. But this time we have feedback from my tutor. So, oh my gosh, let's give it up for my tutor, my diploma tutor. She's called Naz, and honestly, she's been one of the biggest reasons why I absolutely love working in this hospital that I'm working at now. She's been so helpful, and this time around she has kindly added comments. So I've sent her exactly what I did with my queries, and she's added comments of things that she would have done better or things that she wants to share with you. And so thanks to Naz, this on-call video is a little bit different. And also I'm actually going to start doing this from now on. Like I am going to get her to read and see what I did with my queries and talk about how I could have done it better, because I don't have backup on calls. I know certain hospitals have backup on call, but when we're on call, it's just we're on call. So yeah, I'm really grateful that she gave me some comments. But anyway, let's get straight to it. So the first query I got was from a nurse, I think on the acute admissions unit. And basically she was saying that a patient was demanding his buprenorphine. So for those of you who don't know, buprenorphine is sometimes used in pain, but in most cases in community, it's actually used in opioid dependence. And so patients literally need their dose every day. In community, I don't know if you've ever worked in community, but as a community pharmacist, it's your responsibility to make sure that that patient gets their daily dose of either methadone or buprenorphine. And sometimes it's supervised, meaning that you need to be there and watch the patient take it, and then sometimes it's unsupervised. So in this case, my question to the nurse was, okay, does he normally get supervised or unsupervised consumption? How do we know he's had the dose? Where does he normally get the dose? Is this in community? At this point it was like 8 p.m, so I couldn't call the community pharmacy just to verify whether the patient had their dose or not. So we basically did not know, and the nurse couldn't tell me much either. All she could tell me was that he was demanding his buprenorphine. And so I said, okay, is he showing any symptoms of withdrawal? And she again said she's not sure. All she knows is that he wants the buprenorphine. So then I looked at the Trust Opioid Withdrawal Guideline, and it mainly said there that basically giving the buprenorphine, not knowing whether he's had it or not, can be more dangerous, as opioid overdose is definitely more fatal than not giving the buprenorphine, basically. So I went by the guideline, and I was actually unsure whether or not I had to go in for this, because again, we did not stock sublingual buprenorphine on any ward after searching it. So then I spoke to my senior pharmacist, and then she said, no, actually you are correct. Like as per guideline, if we can't verify that he's had it or not, then you shouldn't be giving it, and you don't need to be going in for that. If he was withdrawing, that would be another story, and there's a separate guideline for that. But in my case, the patient was just like saying, I need it, and so that wasn't a good enough reason, and therefore we decided not to supply. And my tutor has said to this, overall the answer given was correct as per guidance, so she was happy with the answer. My second call was from a nurse on ITU, and as soon as I hear ITU, I'm like, oh my god, I'm so freaking scared. But it was from a nurse saying that basically a patient's TPN bag had arrived onto the ward, and this bag didn't correlate with what the patient needed. At this point, my mistake here was contacting the TPN pharmacist. Like I shouldn't have contacted her at this point. And I just said, was it, you know, prescribed by you? Did you guys get it? Like where did it come from? In hindsight, what I would have done differently is I definitely would have found out all these details beforehand. So sometimes I feel like I get a bit rushed and I'm like, oh my gosh, I need to contact the pharmacist in question. But actually, I probably could have found the answer before contacting them, and I could have done it the other way around. But you know, you live and you learn, and and she was really nice about it, so it was fine. But basically I asked the nurse, send me a picture of the patient's bag, send me a picture of the patient's TPN prescription, and tell me what you think is wrong. And eventually what we found was that the last name was missing, which caused a little bit of confusion. So it had been cut off the label on the TPN bag, meaning that it looked like it was for a different patient, although actually the hospital numbers correlated and the TPN bag contents matched the actual TPN prescription. So eventually it was actually fine and there was no problem and the patient could have the bag. My learning in this process was, not finding out the details beforehand. I definitely should have found out the details and then gone to the pharmacist. But because I went to the pharmacist first, she was asking me questions that I couldn't answer. So yeah, that was pretty shit really. Then I got another call from a nurse again about TPN, and this was TPN bag is missing from the ward. Where is it, basically? All I said to her was, okay, if it's missing, TPN is not something that I can personally make or I can go in for. So there's not much that I can do about that, but if you decide to omit the TPN because you can't find it, then definitely give fluids. And my tutor, her comment was, depending on the time, I would confirm with the TPN pharmacist if they ordered a bag for that patient. So really what I should have done is gone to the pharmacist and been like, did you order a bag for this patient today? Were they supposed to get a bag? Do we know if the bag arrived? Didn't do that. I just said, look, if you can't find it, then give fluids. But again, we always live and we learn. And she also said, confirm with the nurse that TPN was prescribed, and if it was decided to omit, then yes, we'd advise to give fluids. So yeah. Okay, now my next query was what ruined my week. So this was a Monday night, but Tuesday morning essentially, and I got a call at 1 a.m. saying, I'm the renal registrar and I need LOKELMA. And LOKELMA is sometimes used in renal patients who, for example, have lost access for their dialysis and they need the LOKELMA to lower their potassium. And so this is like a critical drug. This is potentially life-saving, and we only keep 3 sachets in the emergency drug cupboard. I don't know why, don't ask me why. I know a lot of hospitals keep a lot more, but we just don't. And every time that each sachet is released from the emergency drug cupboard, the site manager has to get the on-call pharmacist's permission. And I had not been called at all that night about LOKELMA. So I was like, oh, okay, that's fine, give me the patient details, why do they need the potassium? And the renal registrar was like really nice, she told me everything and exactly why the patient needed it and the hospital number and the potassium and everything. Then I was like, okay, that's fine, I'm happy with that. Yeah, so get it from the EDC. And she was like, well, I've already spoken to the site manager and there's none left in the emergency drug cupboard. And I was like, well, there has to be, because if the site manager had released them, then I would know about it. So then I briefed the site manager and he's like, yeah, I've given it out already to 3 different wards because the doctors needed it. So I was like, okay, were you aware, like literally on the emergency drug cupboard list, it says contact on-call pharmacist if you need to release this. I was like, were you aware? And he literally was like, how was I supposed to know that? I don't know which wards it was. 10 something or other, and hung up. So after he hung up, I was like, right, he said 10 something or other. So I called 10 North, 10 East, 10 South and 10 West, and 10 South and 10 East were renal wards anyway, and so they were the wards looking for the LOKELMA, so I knew they didn't have any. 10 North and 10 West were like, we don't know what you're talking about, we don't have LOKELMA. So that's when I realised, okay, it's not been dispensed by anyone for 10 South and 10 East, like basically on the renal wards, because I am on my renal rotation. I contacted my colleague who also works on the renal ward, and she said that she didn't have any on her side. So the answer was going in. My poor boyfriend Ed had to literally drive us. It takes us an hour to get to where I work, so he drove us in the middle of the night to hospital, and basically I had to dispense the LOKELMA. And so this leads me on to my next inquiry, which I also answered whilst I was in hospital. So I got a call from a doctor being like, we need ganciclovir, where is it? So I was like, okay, I know ganciclovir, it's kept in the emergency drug cupboard, so if you can't find it right now, contact me right now, because I'm here in hospital, in the dark, by myself. This is the problem about coming in late at night and dispensing and trying to stay awake, really, because my tutor the next day was like, oh, so you just said where they keep the ganciclovir, did you actually ask about why they're not using valganciclovir? And I was like, no. All I thought about at the time was literally supplying it and whether or not I was going to have to come back to hospital. So again, this was a learning experience for me, because she was saying, you know, you could have gone for valganciclovir, which then leads me to my next query the next evening. Can we get ganciclovir for a patient? And by this point I'd already learned, and I was like, actually, do we need ganciclovir? Why not valganciclovir? And so what I did at this point was search on the liver transplant protocol, and it said exactly there that basically if a patient has 3,000 copies or more of the virus, which in this case was CMV, then we can go IV ganciclovir. Obviously, once you're deciding to go for the IV ganciclovir, then I had to counsel the doctor in question and say that, okay, we need to monitor these certain things, we need to monitor renal function, what is the weight of the patient to get the correct dose, and etc. So all of that was done after. But yeah, I'd learned from my previous mistake of simply thinking about supply. And this is the discussion I had with my tutor as well. As a pharmacist, the first thing we should be thinking of is not supply. And most of the time when I'm on call, I'm thinking, wait, can we get it in? Can we get it in? Do I have to go in for it? Do I have to go in for it? But actually, I learned to take a step back and be like, right, is it appropriate for the patient? What other, drugs can we think about? And is it clinically appropriate? Is it indicated? Is it approved? And all of that. So yeah, I've learned a lot from this on call. The next query I got was the dispensary fridge being out of range, and luckily at that point the late duty team was still there, so I just contacted them and I was like, could you please just check if the fridge is in range? Is it because you guys have left the door open? Like, just keep your eye on it. And they did. Then another evening I got a call from a doctor, and I swear like this must have been a prank call or something, because we've just given a patient 600 milligrams of gentamicin earlier on in the day, and the levels come back as 9. So I was like, okay, which ward is it? And who's the patient? What's the hospital number? And he was like, oh, I'm upstairs calling you right now, so I can't give you the patient details, but all I can tell you is that level came back as 9. So I was like, right, well, what's the renal function of the patient? Again, couldn't tell me anything. So at this point I was like, well, the levels come back as 9. You can't tell me the patient details. You don't know anything about the renal function. So 9 is a very, very, very high level. So I basically gave him advice based on tox base, which was discontinue the therapy if that's appropriate, check your full blood count, check U's and E's, check liver function tests, observe the patient for at least 6 hours, and ensure adequate hydration. So all of this was on tox base, which I, then told the doctor. What did my tutor write about this? Oh, she said, advice given is correct, but also remember to think of the indication. Why was Gent chosen in the first place? Was this based on sensitivities? If the patient was not responding to this clinically, then should micro have been involved? So yeah, those are also questions that I could have asked. I think at that point, all I was thinking of was safety, with the level being so high. As my tutor said, was that the only drug chosen? But I also think at this point, the doctor would not have been able to answer me because couldn't even give me the hospital number of the patient, so yeah. Okay, so my next query was also a patient on ITU. Every time like this, seriously, like ITU queries is just another story. And this is probably like at 1 a.m. in the morning, and it's a patient who's just had a PCI and who needed dual antiplatelet therapy. They'd already given PR, like so rectal aspirin, but they also needed another antiplatelet agent, but the NG tube wasn't working for the patient and the patient was nil by mouth. So the question was, what antiplatelet can we give? I felt like this query was way beyond my, expertise, my abilities as a pharmacist. But whilst I was searching, the doctor called me back and was like, oh, actually, cardiology have advised Cangrelor. I had never ever heard of Cangrelor. I was like, what is Cangrelor? Like, I don't know what that is. And I searched it, and we only kept it in stores. And so stores is a separate part of inpatient pharmacy, and I was thinking, oh my god, this is 1 a.m. Like, then I called one of the ITU pharmacists, and thankfully she answered me, and she was like, Cangrelor is kept in the cath lab, and so they need to be opening up cath lab to get it, and it shouldn't be you having to go in. But if they can't find it, then you'll have to go in for it. And luckily they opened up cath lab and they were able to give it to the patient. But yeah, I did a CPD on this. Guys, whenever you don't know something on call, like, make sure that you are doing a CPD on it, because as much as we hate doing CPDs, it does make you learn. So. And one of my next queries was, I was getting constant calls about remdesivir and tocilizumab, which we're using at the moment in some of our COVID positive patients. And so we have a full-on protocol for that, and so that protocol is what I followed. And finally, one of my last queries was basically from one of the hospitals that is nearby, and they said, can you please supply Advigraph, which is tacrolimus? We need this for one of our transplant patients. And I knew this because one of my friends who had previously been on call had done this, but basically we're not a residency pharmacy, and so they shouldn't be coming to us for supply out of hours of medication. My friend actually couriered medication over to another hospital, and then we found out that that was not our protocol, and that the other hospital should have actually tried all of the residency pharmacy and on-call services beforehand. And so I said to him, look, we do stock it, but we can't be the ones couriering it over to you, and so please try all of the other hospitals first and then get back to me if you can't get through. So that one was pretty easy, but I only knew to do that because of my actual friend who did that prior to my on-call. If she hadn't done that, then I probably would have come in and couriered it over. So yeah. Throughout all of this, I was getting constant communication fail alerts, which is basically saying like the fridge can't communicate with the system that monitors the fridge, and even if there's a fail, like it still sets off the on-call bleep, it still sets off the on-call phone. So I think I was, you know, bleeped periodically throughout this whole 4 days of being on call, just every, like, for 2 nights, probably like every hour. So it was not fun, and after that I was burnt out for a while, hence why I didn't film, but I finally gained the energy to film again. So I hope that this video was helpful. Again, this is not like a clinical video which is going to tell you every single detail about every single drug. It's more like a general, this is the kind of call I got, this is kind of what I did, this is what I would do next time. And so I hope that is helpful, and also thank you to Naz, who has given her comments and who is one of like literally the most amazing pharmacists I know and the best tutor. So this video is dedicated to her, and that's all I have to say. So I hope that you enjoyed that video, and I'll see you in the next one.